Good afternoon, everybody, and welcome to today's Public Health Ontario Rounds presentation on Doxy-PEP for STI prevention in cisgender, gbMSM, and trans women. My name is Austin Zygmunt, and I'm a public health physician in health protection at PHO. My portfolios include sexually transmitted and bloodborne infections, so I'm very excited to moderate today's session on this hot topic in STI prevention. Before we begin, I will mention a few housekeeping items. The chat pod has been disabled to limit any distractions during this presentation. Please use the Q&A pod if you have questions during the session, and a discussion and question period will follow the presentation. If at any point during the session you experience any technical issues or if you require CME credits, please email capacitybuilding, one word, at ohpp.ca. I would like to state that as the moderator of this session, I have no conflicts of interest. It is now my pleasure to introduce the speakers for today's presentation, Dr. Jordan Goodridge and Devin Nambier. Dr. Goodridge is a lecturer in the Department of Family and Community Medicine at the University of Toronto and a course director at the Timbertree Faculty of Medicine. He works as a family physician with a specific focus on 2S LGBTQ+ health and HIV primary care. He has a strong interest in medical education, particularly in the areas of sexual health, HIV primary care, and gender-affirming healthcare. In addition, he co-authored the sexual health chapter in the textbook Caring for LGBTQ2S People, a clinical guide. Devin is the manager of capacity building and talent development at the Gay Men's Sexual Health Alliance. He has worked in the healthcare sector for over 22 years and has provided education and training on HIV care, treatment, and 2S LGBTQI+ clinical and cultural competencies to healthcare and social service providers. He's also developed various CME trainings for physician and currently serves on 6 committees, including 2 co-chair of 2 HIV research studies. Happy to pass it on to Devin to begin the presentation.
Thank you very much, Dr. Austin. Good afternoon and welcome everyone to today's session on Doxy-PEP for STI prevention in cisgender, gay, bi, MSM populations and transgender women. I'm very pleased to present this with Dr. Jordan Goodridge. So we both have our disclosure here on the slide. So please take a second to read this. Moving on, this presentation was created by myself and Dr. Jordan Goodridge. The presentation will be available online in a couple of weeks from Public Health Ontario. Some of the learning objectives for today is to interpret research studies, and you're going to be seeing a lot of the different research studies and the different outcomes, the efficacy of doxycycline post-exposure prophylaxis for sexually transmitted infections. We're going to be looking at the benefit and risk ratio of Doxy-PEP in gay, bisexual, and other men who have sex in men, transgender women, and people living with HIV. We're also going to be discussing how to implement access and facilitate removing barriers for sexual health discussions in clinical settings. To develop competencies in prescribing Doxy-PEP, what are some current guidelines for gay, bi, MSM populations, transgender women, and people living with HIV. So who is Gay Men's Sexual Health Alliance? So the Gay Men's Sexual Health Alliance is funded by the Ministry of Health AIDS Bureau to increase the capacity of frontline HIV services to two-spirit, gay, bi, trans, queer men who have sex with men. We also have various resources and campaigns on our website, including for healthcare providers and other community members. In the presentation outlined today, we're going to be looking at STI rates across Ontario, HIV PrEP. So for those of us who are not familiar with HIV PrEP, we do know the context of HIV PrEP, especially in STI infections. We know since the use of HIV PrEP, pre-exposure prophylaxis such as Truvada and Descovy, there's been an observed increase of condomless sex, which facilitates transmission of STIs, and looking at biomedical prevention of STI. The efficacy of doxycycline in reducing STI prevention, the concerns around prescribing Doxy-PEP, including antimicrobial resistance, and describing details of Doxy-PEP when indicated. We will explore one case scenario and a few polls, and then we have a session on Q&As. Just to give a bit of a context of burden of STI. So we know from Public Health Agency of Canada, we know in Canada, gay, bi, MSM populations, transgender women are disproportionately impacted by STI infections across the country. From an Ontario STI lens in Ontario, from PHO's website, we know in 2021, chlamydia trends of 35,389 cases, and for gonorrhea, 9,814 cases, and for syphilis, 2,946 cases. So the trends, if you look at the website, PHO's website, you'll see the trends are slightly increasing over time. So in today's conversation, we're talking about doxycycline. Doxycycline has been a very hot topic in the last couple of years. There was a lot of presentations earlier this year at the Conference on Retrovirus and Opportunistic Infections at the CROI conference. So doxycycline is an inexpensive antibiotic prescribed to treat acne, malaria, and bacterial STIs, right? So it belongs to the class of tetracycline drugs. And this is something we were talking about earlier today further on. Now, we're going to be reviewing also this study. So in this publication here, if you look at clinical infectious disease, there were 9 studies listed in here, and 6 of them were on doxy pre-exposure prophylaxis, basically taking doxy daily. However, for today's session, we're going to be looking at doxy prescribed after condomless sex. So the prescription is basically 200 milligrams taken within 24 hours for up to 72 hours. And Dr. Jordan Goodrich is going to be going further into the studies by Dr. Molina and Luca Maya in terms of actually what these studies are telling us right now and how that's going to help you in your clinical practices. There is no, in terms of guidelines, there is no guidelines from this Center for Disease Control in the US. They do have a consideration since 2021 in terms of prescribing Doxy-PEP. So the guidelines came from the California Department of Public Health earlier this year, right? So the guidelines here is to recommend Doxy-PEP to men who have sex with men or transgender women who have greater than 1 bacterial STI in the last 12 months. To offer Doxy-PEP using a shared decision-making process to all non-pregnant individuals at increased risk for STIs. Doxy-PEP is not recommended for pregnant individuals. And to those requesting Doxy-PEP, even if these individuals have not been previously diagnosed with STI or have not disclosed risk status. And lastly, to provide comprehensive preventative sexual health counseling and education to all sexually active individuals, to include HIV STI screening, Doxy-PEP, and pre-exposure prophylaxis, including vaccination with hepatitis B, HPV vaccination, and expedient partner therapy or contraceptions where warranted. And I believe the next slide is for Jordan.
Great, thanks so much, Devin. So for the next part of the presentation, I'll actually discuss data from the 3 Doxy-PEP trials that Devin highlighted there. The first of the 3 trials that got published in 2018 took place a couple of years prior, and it was actually a sub-study of the IPER-GAY trial. So for those of you who don't know, IPER-GAY was really the landmark trial that looked at intermittent or on-demand HIV PrEP using tenofovir and emtricitabine. So the Doxy-PEP sub-study took participants from only the France sites there, and about 232 men who have sex with men and trans women who are on-demand HIV PrEP were then randomized 1-to-1, either to receive doxycycline post-exposure prophylaxis, which in this study was a single oral dose, 200 milligrams of doxycycline, taken within 24 hours after condomless sex, versus the no PEP group, who weren't assigned any placebos, who were just kind of standard care, essentially. And then they conducted STI testing at, interestingly, every 2-month intervals here, up to 10 months. The primary endpoint of which being the occurrence of any first bacterial STI, specifically gonorrhea, chlamydia, or syphilis, during the 10 months of follow-up. And for this, they used the hazard ratio for measurement, as I'll kind of outline on the next slide. So here you can see the results for chlamydia and syphilis reduction specifically. And what it showed was that those individuals who took 200 milligrams of doxycycline, within 24 hours, aka the Doxy-PEP group, had an overall 70% lower chance of acquiring chlamydia over those 10 months of follow-up, and a 73% less likelihood of acquiring syphilis at least once, again, over that 10 months follow-up. So pretty significant results already. One thing I do want to highlight from this trial, though, is that they didn't find a significant decrease in the rates of gonorrhea infection in the Doxy-PEP group. It was largely attributed to high baseline tetracycline resistance of gonorrhea in France, about almost 60% at the time of the study, which, as I'll get to later in the presentation, is higher than it is in Canada and pretty significantly higher than in the US. And in keeping with this high resistance rates, they saw that of the 9 positive gonorrhea cultures taken over the course of the study, 7 were found to be tetracycline resistant. And I'll get into that a little bit later as well when we talk about resistance later in the presentation. But I just wanted to give you that brief overview of that first study. The second study I want to highlight was actually just published earlier this year. In this study, it was slightly larger, 501 men who have sex with men or transgender women who made up a very small portion of that overall population. Living in Seattle and San Francisco, were assigned to either Doxy-PEP or the kind of routine care group. So interestingly, in this study, there are 2 subsets. There are individuals who are on HIV PrEP, and there was a group of individuals living with HIV. And so those were included in the inclusion criteria. They also needed to be diagnosed with 1 STI in the last year to be eligible for inclusion. So in contrast to the previous study, though, I do want to highlight this study used a 2-to-1 randomization. And what that means is that 2 participants were assigned to take Doxy-PEP for every 1 participant who were taking no Doxy-PEP. And I'll talk about why that's important a bit later as we look into some of the data that came out of the study. But another difference in this study, participants were encouraged to take Doxy-PEP kind of within 24 hours after condomless sex, but they were actually allowed to take it, they're told, up to 72 hours afterwards. STI testing was done every 3 months in this study, which is more in keeping with what we traditionally do, with our patients who are on HIV PrEP, for instance. And so from these results, again, they used a similar primary effectiveness endpoint. Here, the incidence of at least 1 bacterial STI. Again, they lumped chlamydia, gonorrhea, and syphilis all into 1 for the primary effectiveness endpoint, and then I'll talk about how they divided it up later. But what I want to highlight here is that you can see for both the PrEP cohort and the people living with HIV cohort, there's a substantially lower incidence of at least 1 STI in the Doxy-PEP group. And that's represented by that bluish gray, the 2 lines at the bottom, compared to the standard group in red who did not receive Doxy-PEP. And so at the bottom of this slide, you can see some hazard ratios that I've highlighted in the bottom right corner. Basically here, hazard ratios being 0.34 and 0.48 for the 2 groups means, in other words, that the primary effectiveness endpoint found a 66 reduced incidence of at least 1 bacterial STI for those who are in the Doxy-PEP group who took PrEP, and then a 52% reduced incidence for the people living with HIV group who took PEP. But I think it's also important to break it down into the individual STIs as well. So as a secondary endpoint, the study authors did also look at the percent of quarterly visits in which each of these bacterial STIs were detected. And so to kind of orient you to the slide, on the left side, you can see 2 sets of bars indicating the PrEP cohort. And then on the right side is a people living with HIV cohort. And again, 2 separate bars where it might be cut off on your screen, but essentially in each set of bars, on the left is the Doxy-PEP group, and on the right is a standard of care group. Okay, so what you can see from this is that the relative risk of being diagnosed with each STI in a given visit was significantly reduced. And so when they actually calculated out, it was about a 55% reduction in the rates of gonorrhea, about a 74 to 88% reduced rate of chlamydia, depending on if you were in the PrEP or the people living with HIV cohort, and a 77 to an 87 reduction in syphilis risk. So really impressive results in terms of reducing STI incidence in these 2 groups. Interestingly enough, the authors also broke it down into different sites and of infection, so urethral, pharyngeal, rectal. For instance, you can see gonorrhea and chlamydia, that the majority of infections were either pharyngeal and rectal, and it seemed that Doxy-PEP was quite good overall at reducing incidence in all areas. So again, that was the second major trial that found really high effectiveness, particularly in reducing syphilis and chlamydia rates. But that trial did find a reduced rate, in gonorrhea as well. And that may in part be because this was done in the US, as I mentioned, on the West Coast, where there are lower rates of gonorrhea resistance to tetracyclines. And then the last of the three that I wanted to touch on is the Doxy-PEP trial. The estimated study completion date that they provided was actually in this month. So we'll see when the results are finally published. But the trial authors did actually speak about this, as Devin mentioned, in the CROI conference earlier this year. So it's an ongoing trial. This is also a trial that's being done in France, again, important because of higher gonorrhea resistance rates to tetracyclines. And this group involved or enrolled men who have sex with men who have been on PrEP for at least 6 months. You may have also heard about the Preventive trial. This is probably the second big landmark trial looking at intermittent or on-demand HIV PrEP. So individuals who were enrolled in that trial were eligible for this. Again, they also had to have been diagnosed with a bacterial STI in the prior year and have no STI symptoms at the time of intake. So very similar inclusion criteria to the last study that we just talked about. They also did 2-to-1 randomization. So again, 2 people assigned to Doxy-PEP for every 1 person assigned to no PEP. And again, they were told that they can take PEP up to 72 hours after, but that it's recommended ideally to take it within about 24 hours after condomless sex. And then as you can see at the bottom here, the primary endpoint, here the study was focusing on the probability of chlamydia or syphilis. From the previous trials, we'd seen kind of a better effectiveness or prevention of that, but the study authors did also look at gonorrhea infection as well, as I'll talk to you about a little bit. So here are the overall results. Again, the primary endpoint being reduction in the likelihood of acquiring syphilis or chlamydia. And the results were extremely impressive, right? So about an 84% reduced likelihood of acquiring either of those bacterial STIs over the course of the study. So really just more data adding on to suggest efficacy for Doxy-PEP in preventing STIs. When you break it up into each of these STIs, here I've highlighted chlamydia and syphilis. You can see that with chlamydia, there's almost a 90% reduction in terms of likelihood of acquiring chlamydia over the time of the study, and almost an 80% reduction in the probability of acquiring syphilis. So recognizing that these are infections that are, quite on the rise, that can have significant implications and consequences, particularly if untreated or in individuals who are immunocompromised or have other certain risk factors for more significant infection. This is really highlighting that Doxy-PEP can be one potential tool for helping to try to reduce overall rates in our communities. And interestingly, so as I mentioned, this was also done in France. Actually, the main primary author from the first trial that I showed you that was published in 2018 is also the main primary author here, Molina. And interestingly, so although this is also done in France with its high gonorrhea tetracycline resistance rates, this study was probably better powered to detect a reduction in gonorrhea if there is any. And so this study did find slightly more than 50% less likelihood of acquiring gonorrhea over the time of the study. So that's pretty remarkable to say that even in high baseline tetracycline resistance rates, there is still a reduction in gonorrhea infections. I was happy to see that this study was the only one to also routinely test for Mycoplasma genitalium. This is a bacteria that we don't routinely test for in all of our patients here, but that we're recognizing, I think, more and more over time that is a possible cause of urethritis, particularly where gonorrhea and syphilis are negative. And this is important because Doxycycline is the go-to treatment now for Mycoplasma, over time, it kind of shifts back and forth between doxy and azithromycin. But lately, there's been increased azithromycin resistance rates in mycoplasma. So, we've leaned back towards doxy a little bit, and that's why it's important for us to consider resistance in this organism. But the good thing that we found, I'll talk about resistance later, but when it comes to its likelihood of reducing mycoplasma infection, we saw that the risk was 45% less in the Doxy-PEP versus the standard care group. So again, that's pretty significant reduction by about half. And so that trial gave us more data demonstrating the effectiveness of Doxy-PEP, not only in reducing chlamydia and syphilis, but also adding to data that says that it may be a useful tool for reducing gonorrhea infection, which is one of the STIs that we detect most commonly in our men who have sex with men and transgender women, even in the face of high baseline resistance rates. Devin also alluded a bit to the DPEP Kenya trial. So this is the one study that looked at Doxy-PEP's efficacy in reducing STI rates in cisgender women. This study results have not yet been published. We're waiting for that, but it has been presented. And specifically, this trial was looking at rates of chlamydia and gonorrhea, and unfortunately found that in cisgender women living in Kenya who were enrolled in the trial, there was not a reduced risk of these infections in the group assigned to take Doxy-PEP. So now we, of course, start to wonder why that is, right? I think it's clear that part of the reason of lack of efficacy can be explained by the high rates of antibiotic-resistant gonorrhea here. But again, that, of course, doesn't explain why chlamydia rates were not reduced using Doxy-PEP. This study authors actually felt like it was most likely due to suboptimal adherence. They recognize there's some significant barriers for Kenyan women in terms of their ability, willingness, or safety around taking Doxy-PEP. That can't go ignored, right? So that seemed to be, one of the likely reasons behind. They made note that they're evaluating the frequency and timing of doxycycline doses a bit further to be able to try to figure out what might be going on. And there was also a theoretical consideration or concern that anatomical differences between cisgender women and transgender women or cisgender men could explain why Doxy-PEP wasn't found to be as effective. While this was postulated, a different study that was presented during the conference, during CROI, actually suggests against this as a reason. What this separate study did, which I won't go into huge details about, but they looked at doxycycline concentrations in vaginal and rectal secretions and tissues, and didn't find a substantial enough difference that we could necessarily explain this finding or attribute it to anatomical differences. So, I think we may benefit from getting ongoing studies. It'll be interesting to see this study when it's published and whether the authors had come to any conclusions about why the efficacy wasn't really seen in this population. All right, so next I'm going to talk a little bit about, if you were to prescribe Doxy-PEP, how is it actually done, right? And you will probably be not too surprised at the dosing regimen. It reflects very closely what was actually studied in the trial. 200 milligrams of doxycycline, ideally within 24 hours of unprotected sex. And that includes oral sex, anal sex, and or vaginal sex, right? So I think a lot of people, recognize STI risks through penetrative sex, anal and vaginal, but it's important to also counsel patients, especially with high rates of pharyngeal gonorrhea, for instance, and its potential syphilis transmission through that route as well, that it's important to take Doxy-PEP if prescribed it after those potential exposures too. Of note, and this is similar in some ways to intermittent or on-demand HIV PrEP. So if they were to become sexually active again within 24 hours, then they should repeat their dose, again, within 24 hours after their last dose, which is pretty similar to what we do for on-demand PrEP. It's also important to counsel, of course, patients on any side effects of medications that we start. The trials found a very low likelihood of side effects. In the realm of about 10% increase in terms of GI upset, things like nausea, upset stomach. Some of the trials, but not others, found a few links to a bit of increased risk of diarrhea. But yeah, overall, the rates were quite low, and this medication was very, very well tolerated. We also talk about photosensitivity with doxycycline and recommend that patients wear sunscreen daily to help prevent this. And less common is esophageal irritation. And to help prevent that and reflux, we recommend avoiding lying down for about half an hour after taking Doxy-PEP. Contraindications, as I've alluded to, because it's teratogenic, we say not to take if you're pregnant. And it should ideally be spaced out from dairy, calcium, antacids, multivitamins, things that contain kind of the metal ions, right? The irons, calciums, etc. That could otherwise bind or chelate to doxycycline and prevent optimal absorption. But for the next part, I'll actually pass it back to Devin.
Thank you, Jordan. So there's been a lot of conversations about, providing antibiotics to patients and the drug resistance. So some conversation has been more data is needed to understand the long-term effects for individuals as well as broader communities. Also, some clinicians have said if you keep exposing patients to antibiotics like doxycycline, are you raising the risk that patients are going to be colonized in terms of gastrointestinal issues or infected with a resistant strain sometime in future? But however, the benefit of doxycycline, as we've seen in the study, has provided consistent reduction in STI infections for clients, right? So basically also reduce patient visits to providers. Some of the other issues has been basically the disruption to the gut microbiome. So how is this affecting the gastrointestinal tract, other outcomes in terms of gastrointestinal tract health? There are also concerns about population-led antimicrobial resistance. In one study with Doxy-PEP, in some of the studies you saw earlier, they found actually Doxy-PEP appears to be less effective at treating gonorrhea due to pre-existing drug resistance towards tetracycline antibiotics. So this is an ongoing conversation, but always looking at the potential benefit versus potential harm. Here are two quotes from two physicians, basically looking at a sex positive attitude in terms of actually looking at the benefit of prescribing antibiotics to prevent STI infections, which has been steadily increasing the last few years across all sectors and very many populations. So here to read out, my goal as a physician is to make sure my patients are able to have whatever type of sex they want, however much sex they want, as safely as possible. If Doxy-PEP would allow them to do it, then I have no problem offering it. We have used Doxy-PEP for multiple other things, right? And so basically, and I think specifically now being like, we're not going to do it because of antimicrobial resistance, when it's specifically related to STI, it's a good time to call out is the stigma and bias. Other physicians have also called out, what are the concerns when we're prescribing Doxy-PEP for teenagers for acne? Are we talking about drug resistance? So there's many conversations how to create a much more holistic, inclusive practice in terms of talking about sexual health with your clients who are part of the transgender women's population and gbMSM population and people living HIV. I think, Jordan, the next is yours. Yep.
Great. Thanks so much, Devin. So next, we're going to be talking about resistance patterns, both resistance of gonorrhea specifically here in Canada, as well as the resistance data that we have from the trials that I've already talked about. So as you can see from this graph here, the rates of gonorrhea resistance to tetracycline specifically, which doxycycline, of course, is in the class of, has increased over time. Interestingly, it's not an all-time high. So if you look at, around 2015, that's when there was a bit of a peak of doxycycline resistance, and the rates seem to have come down a little bit since. But the reason, of course, that we bring this up is it's reasonable to consider, or it's important to actually think about, will Doxy-PEP significantly increase the rates of resistance of tetracyclines by various organisms, including gonorrhea? One thing I do want to illustrate here, however, is the fact that the rates of decreased susceptibility to ceftriaxone, which is that kind of like brownish sort of line on the chart here, has not increased over time and actually has kind of decreased in the previous few years. So the reason that I bring this up, the reason that's important, is there's some theoretical concern that doxycycline use, might increase the rates of ceftriaxone cross-resistance, because really we don't use doxycycline to treat gonorrhea, right? So we may be less concerned about doxycycline resistance in and of itself for gonorrhea strains, but more concerned, of course, if it would affect the likelihood of our first-line treatments like ceftriaxone working against it. But what you can see is as doxycycline or tetracycline resistance in general has increased, ceftriaxone reduced susceptibility hasn't increased, right? And it's actually decreased over the previous years. So that's actually somewhat reassuring about, the lack of increase in ceftriaxone resistance in the context of doxycycline, through potential cross-resistance. Of course, the concern about antibiotic resistance extends beyond gonorrhea to other bacteria. So that's what I'll try to be highlighting a little bit in terms of what data we at least do have in terms of resistance reviewed in the trials. So the first of the trials I talked about, again, that sub-study of the IPERGAY trial, looked at gonorrhea resistance rates to tetracyclines. Although I felt like they didn't necessarily report on them in the easiest to interpret ways. The data that they have told us here is that 9 positive gonorrhea cultures were taken from 8 participants. Of these gonorrhea cultures, 2 participants were in the Doxy-PEP group and 6 participants were in the no PEP group, right? And we recognize that even if doxycycline might not fully prevent gonorrhea in some individuals, it may reduce the sort of overall levels, right, of gonorrhea. And so there may actually be a lower yield and a less ability to culture all of these patients. So I think that that's something to recognize as a potential limitation here. That being said, one of the things that the authors did note that's actually pretty reassuring is that at least how they define full tetracycline resistance in this study, they found that that occurred in 4 isolates, but all 4 of these fully resistant gonorrhea strains were from the no PEP group. So from this, very small amount of data, of course, recognizing those limitations, we at least don't have a concerning evidence for increasing, full tetracycline resistance from Doxy-PEP. They also noted that intermediate resistance was found in 3 of those 9 isolates. Unfortunately, they didn't comment about which group they came from. So there's only so much that we can extrapolate from that data. I feel like the second study did talk about it in a little bit more detail when it comes to doxycycline resistance. So again, this is the trial that was done in Seattle and San Francisco. They measured doxycycline resistance using cultures as well, both at baseline and throughout the trial. And I want to highlight here at baseline, that first bar on the left, about 27% of the samples were resistant to tetracyclines. They used a slightly different minimal inhibitory concentration, but I think the ultimate point is the same here. So 27% is similar to rates that they see in the US. They often say it's in the 20s. So that's consistent with what we'd expect to see. And then of the participants that in follow-up had gonorrhea cultures available, and again, so those were done in individuals who tested positive on NAT, on the nucleic acid amplification testing, or who were symptomatic and suspected to have gonorrhea. Tetracycline-resistant gonorrhea occurred in 5 of the individuals in the Doxy-PEP group, indicated by kind of the darker bluish green, and 2 individuals in the standard care group, right? So what you can kind of gain by looking at these graphs here, these bars, is that the resistant to non-resistant ratio was higher probably in the Doxy-PEP group. This observed difference, though, was likely actually in part due to Doxy-PEP's efficacy in reducing the non-resistant gonorrhea rates, right, rather than an actual increase necessarily in doxycycline resistant strains of gonorrhea. And I alluded earlier in this presentation to how individuals were randomized 2-to-1. So again, for every 2 individuals randomized to doxy, 1 individual was the usual care group. So actually, given this 2-to-1 randomization, if you're just looking at sheer numbers of doxycycline resistant gonorrhea, what you might expect just that, baseline, if doxycycline doesn't induce resistance, is about twice the absolute number of gonorrhea infections in the Doxy-PEP group, right? Because again, 2-to-1 ratio. So as we see here, the actual absolute number was 5-to-2. Again, it's very small in terms of sample size, but it doesn't suggest necessarily a significant increase in the risk of doxycycline resistant strains. The study, is interestingly enough, also did look at Staph aureus. As you may be aware, especially MRSA, methicillin-resistant Staph aureus, we typically will use an agent like doxycycline in the treatment as needed. And what we can see by looking again at the darker bars that indicate resistance is that overall, and I think I've highlighted them. Yes, here we go. What we can see is approximately 5 resistant strains in the Doxy-PEP group, again, to 2 in the usual care group. So again, that same ratio that we saw with gonorrhea, we're seeing with Staph aureus here, which is similar to what we said with the 2-to-1 pattern, right? Although there's some limitations here, like the median follow-up of the study actually only being 9 months, this is still reassuring in terms of the short-term risk, at least, of inducing doxycycline resistance, although with a caveat that we would benefit from some longer-term data to see if that risk increases further over time. And then finally, I want to highlight in the Doxy-VAC trial, again, this is the one in France that hasn't yet fully been published. They did also measure baseline resistance and resistance as well throughout the trial. They found that at baseline, all 7 of 7 culturable gonorrhea were resistant to tetracyclines. And unlike the other 2 studies, here they broke it up into resistant versus high level of resistance. And so they used different minimal inhibitory concentrations. I won't go into that in huge detail, but yeah, it's interesting to note that each study had kind of different cutoffs. The takeaway, though, what I want you to focus on is that, again, although the proportion of highly resistant gonorrhea looks higher in the Doxy-PEP group, as indicated by that red bar there, it's actually lower than what we'd expect it to be given a 2-to-1 randomization. So if you're looking at, again, the absolute numbers, it's actually 7 individuals in the Doxy-PEP group who were found to have high levels of resistance versus 7 in the no-PEP group. And given that, again, they were randomized 2-to-1, that actually, to me, is reassuring that at least in the short term, there wasn't a significant spike or increase in significant or high levels of tetracycline resistance. So next, I'll go into a bit of a case to get our brains thinking and to also see where you're at after we've talked a little bit about resistance. Let's say you actually have a patient now who's coming into you. He's a 31-year-old cisgender man who has sex with men. He presents to the clinic requesting Doxy-PEP, which he has read about online. First, I want you to take a second. If you're thinking about prescribing Doxy-PEP, what additional info would you want to know? And I'm going to pause to let you actually think through it a little bit. All right. And then I'll give you the answers. So, of course, we want to take a detailed sexual history, recognizing that we want to see, is this an individual who's at increased risk of acquiring STIs or, higher complications with them? Obviously, are there any allergies to antibiotics like doxycycline, et cetera? And then from asking these questions, so he's on HIV PrEP, he gets regular testing every 3 months. In terms of last year STI history, he was positive for primary syphilis and pharyngeal gonorrhea, each once in the past year. he endorses condomless oral sex 100% of the time and condomless anal sex about 90% of the time. And here I grade out insertive and receptive. While that can still be, of course, useful for us to know for different reasons, we recognize that, of course, both acts can transmit pretty easily chlamydia, gonorrhea, syphilis. He approximates about 5 to 10 casual partners on the average month and does not anticipate any changes to his sexual practices in terms of condom use, in terms of numbers of partners, et cetera, et cetera, et cetera. So before we end off, I'm going to summarize a bit of what we talked about, pass it over to Devin for a little bit, and then we're going to take the Q&As. But in summary, the 3 large studies that we have on Doxy-PEP so far have shown significant reductions of bacterial STIs, particularly among men who have sex with men. Even the studies that enrolled trans women had lower or had overall quite low rates of transgender women. But we can extrapolate and actually still assume that it's likely to have good effectiveness in this population. It's now actually become the standard of care in California, which is very interesting. Other parts of the world have taken a stance against it, and a lot of areas, you know, it's a bit to be determined, right? But there are absolutely local healthcare providers who are currently prescribing Doxy-PEP. So I think it's worthwhile to consider as a possible tool to further reduce STIs and reduce the consequences of congenital syphilis, of ocular blindness, of, you know, all of those things that we still do see are actually on the rise. Doxy-PEP we know is well tolerated, both from these studies as well as clinical use, and have a high self-reported adherence, which I think there's a question about, so I can get to later. But we're still waiting for further studies for more antibiotic resistance data. Over to you, Devin.
Thanks, Jordan. So for everyone who's interested, we do have a fact sheet that Jordan and I wrote together. It's available online at GMSH website. And there also will be 3 more fact sheets coming up over the next week that Jordan and I also wrote on basically health promotion for gbMSM population, on syphilis, chlamydia, and gonorrhea. Now, for those of you who are not familiar with GMSH, you can connect with us online and through email. And lastly, to let you know, for anyone who's interested in Toronto, Ottawa, and Hamilton, we have a study that's a CTN study, 329, Canadian HIV Trials Network study. Basically, the study is enrolling in the 3 sites, Toronto, Ottawa, and Hamilton. In Toronto, it's in St. Michael's Hospital with Dr. Daryl Tan. So here's the website link, and the inclusion and exclusion criteria is listed there, along also for those of you who want to share the QR code, is available online. And those are my updates, and then I'll pass it over to Austin for the Q&A.
Thanks, Devin and Dr. Goodridge. We will now move on to our Q&A segment of the event and address some of the questions from the audience. There are already a lot of questions in the chat, but if there are others from the audience, please enter them in now. So the first question we have is around adherence to Doxy-PEP in these studies. So Jordan, would you be able to speak more to this? Were the individual participants taking PEP after every intercourse, or is there more information?
Mm-hmm. Yeah, absolutely. I wonder too, actually, Devin, would you be able to maybe put up the adherence slides once more? I know we just took them away, but I think it might be useful for the participants to see. So essentially, the studies use different indicators to mark adherence, right? So some of them use pill counters, some of them actually measured drug levels. One of them did. And one of them relied on self-report data. The second of the studies by Luke Meyer did all 3, and the others were mostly around self-report. And so people's self-reporting of Doxy-PEP was pretty good in terms of adherence. What we found is that it did kind of slightly reduce over the course of the study. Those who, from the first study, those who said that they took Doxy-PEP after every sexual encounter that was condomless was about 50%. So, you know, really not super high. But another 30 to 40% of individuals endorsed that they took Doxy-PEP after most condomless oral, anal, or vaginal sex. And then a small percentage, about 10% to 20% at a time, said no, they actually didn't use it in the preceding 3 months. So Adherence was not perfect. And what I usually kind of garner from that, like some of our early HIV PrEP studies, is that, the actual efficacy of reducing these STIs may actually be higher than what we've seen in the studies. Devin, I'm not sure if you're able to pull up the slide. Oh, you're muted.
Which slide did you want?
Yeah, if you just go to the appendix, and I can kind of
got it.
control over the. Great, thank you so much. And we can take another question maybe while that's being pulled up.
Sure. So there was a question on if there have been any studies that have looked at alternative regimens for dosing, so like a 2 or 3 day dosing as opposed to just a one-time dose for PEP.
Yeah, great question. There hasn't for PEP, for Doxy-PEP. There have been the other trials. There was one study that actually looked at Doxy-PrEP. So again, taking it as pre-exposure prophylaxis at 100 milligrams a day, but that's starting before and continuing during high-risk periods. Other studies around Doxy-PrEP and Doxy-PEP were actually just studies asking about what people's feelings were towards it, whether they thought it was like a reasonable treatment that they would consider, blah, blah, blah. So we don't have a ton of data on other dosing regimens. The one study on Doxy-PrEP did seem to be quite effective. I think, again, it was about the 70 to 75% range of reduction in terms of chlamydia and syphilis. But yeah, no dosing strategies that would do, let's say, 200 milligrams followed by, any other doses if they weren't, again, sexually active.
Yeah, there's lots of questions on how you actually prescribe this in practice. So do you prescribe a one-time dose for patients, or do you give them several supplies of doxycycline to take as needed?
Yeah, what I'd probably recommend, so how they did it in the trials is very similar to what we do as well, actually, for on-demand HIV PrEP. So if you've prescribed on-demand HIV PrEP, you've also probably had to face this conundrum of how much do I prescribe at a time, right? Based on how much do I think the individual will use in part. The study would either do kind of 2 months worth of, or 60, no, wait, what did they do? They did 2 bottles of 30 or 3 bottles of 30, recognizing that they take 2 pills at a time, but that they're not likely to need it, every single day. And that seemed to work pretty well. So I would probably recommend the same thing, gauge based on your patient's prior sexual history, and if there's any anticipated changes in terms of sexual behaviors, you can estimate how many pills they might need in that time. But the good part ideally is that if these are individuals who are already on HIV PrEP and engaged in care or living with HIV and you're doing STI testing every 3 months, that's really the main thing is, we want to make sure they're still engaged in care, that we have that testing done. So usually there's still, that part isn't an issue. So even if you quote unquote overprescribe, I don't anticipate that it's going to be too big of a deal.
Also have a few questions around the California Department of Public Health recommendations and their applicability to cisgendered women. Do you have any particular recommendations for that group in the use of Doxy-PEP?
Yeah, good question. So, and this is just, personal, because of course everyone will have their own different feelings and opinions and whatnot. But I think, again, when we're weighing the benefits and the risks, the downside is that we don't have evidence right now of good efficacy of doxycycline in preventing STIs in our cisgender women. So, in the absence of known benefit, but in the presence of potential risk, right, when it comes to long-term antimicrobial resistance, this would be a population where I probably wouldn't lean towards necessarily using it. Might I consider it in individuals who are particularly high risk in terms of number of episodes of unprotected sex and maybe sex work or other considerations, potentially, but I think we have to recognize though that we don't yet have data that actually tells us it's effective in this group, and because of that, I'd probably lean away towards more routinely prescribing it.
There's another question about some of the demographic variables of individuals in these studies. Did they look at factors such as ethnicity or differences between different members of the 2S LGBTQ community?
Yeah, good question. I think, Devin, were you able to pull up the slides by any chance? You're muted again.
Got the one on
There's some of the
Doxy-PEP
demographic
self-adherence.
yeah, you can just put it up and I can control it. That's no problem.
It's up.
Oh, are others able to see it?
No.
Oh, it might be the
Was
view.
it maybe unshared?
It's okay. I can second computer in case I needed it, because with technological issues there. Just to kind of give you an idea. I mean, I think if we're able to, it might be easier to just show you kind of the baseline characteristics. But yes, they did look at some baseline characteristics. For instance, I think the Lutkemeyer study probably reported in the most detail about 2/3 of individuals, so being race-based data, 2/3 being white, 5 to 13 people or percent of people. Start my video. Are identified as Black depending on the group. Asian Pacific Islanders between 5 and 14%, and then individuals with multiple races or other about 14 to 17%. So there is a representation between a decent representation of different groups, though predominantly white. As I mentioned earlier, there's a lower portion of transgender women, compared to cisgender men who have sex with men. So about 4% overall were trans or gender diverse. And then they also did baseline data about what the STI was over the previous year, substance use in the past 3 months, average age, etc. So those were all done at baseline, and there wasn't a statistically significant difference found between groups.
Thank you. So seeing the time, we will wrap up today's session. Fortunately, there are still over 20 questions we weren't able to get to, but I would like to thank Dr. Goodridge and Devin for presenting. I'd also like to thank everyone for attending today's webinar. You can expect to receive a brief and anonymous PHO round survey for today's session. Please try to complete this to help us improve our programming. A reminder to everyone to save the date for topic, which is the Ontario Public Health Convention. This will be held in person on March 26th of 2024 and virtually on April 3rd. This conference is now accepting abstract submissions, which are due by October 20th. And you can check out topic, which is tophc.ca for details. And lastly, to access past PHO presentations and to view confirmed and upcoming sessions, please visit the PHO website. Head to Education and Events and click on Presentations. I want to thank you all for attending and have a wonderful day. Take care.